Listen up, y'all. Big announcement with regards to the Cabo course. Matt and Mike done told you about this course. It's in Cabo. Wayne will be there. Bravo will be there. Andy Slopes will be there. Levitin will be there. Yeah, it's still all inclusive on the beach, but it just got amped up to the max, dog. It's not just amazing lectures now. Now they're gonna get down and dirty with you. Hands on ultrasound with your podcast homies. Hands on airways with the world's greatest airway teachers. Play with some nasty equipment and learn some off the hizzle techniques to save a life the next time a crashing patient comes in. Where else you gonna learn airway from Levitin, Wayngard, and Slopes, ultrasound from Mike and Matt, and see a shirtless Rob Orman? Obviously, I can't come because, well, you know what happened last time I was in Mexico. But if you're not like me and don't have your picture up at every border crossing, then you better get there. It's in less than 2 months. Time is running out. December 5th to the 7th. Go to www.caboseme.com. You're a fool to miss it. Dr. Puppet out.
Well, actually, it's the 5th through 9th. But hey, that's what happens when you hire a puppet to be your spokesman. www.cabocme.com, 5th through 9th, not the 7th. See you then. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
3 years of podcasts and nothing on pregnancy. Kind of crazy considering every single time we scan a patient, there's one wise guy in the room that says, hope he's not pregnant. And maybe that's why we haven't covered it. Everybody knows you can scan a baby. No big news here. But not everyone may know exactly how, so we need to cover it. Just to clarify though, we will not cover how to tell the gender of a baby. Possibly my biggest pet peeve ever is getting asked to tell what the sex of someone's baby is. I'm normally a pretty nice guy, but for some reason that just grates on my nerves in the emergency department like nothing else. I usually tell them that, I'm not that good at it, but I'm happy to take a shot at telling them the race of the baby if they'd like. Personally, I just think it's a more exciting scan, especially with the whole extended family gathered around. My success rate, it's probably about 20%, but it makes for a really fun family experience regardless of whether I'm right or wrong.
All right, so pregnancy ultrasound. So we're going to talk about the use of ultrasound in early pregnancy in this module. And there's lots of reasons that we use ultrasound in pregnancy, and those include things like pelvic pain in pregnancy, vaginal bleeding, and the main reason that we apply ultrasound in these cases is to rule in intrauterine pregnancy and help make sure that we're not dealing with patients who have a life-threatening illness like an ectopic pregnancy. We can also do things like determine viability, but technically we don't really rule out ectopic. We just rule in IUP, and we'll talk about that in this particular lecture.
Yeah, that's kind of a pet peeve of mine when I hear people say you can't really rule out an ectopic pregnancy by ruling in intrauterine pregnancy, even though the risk is so low, 1 in a few thousand. The point is we never rule out anything really in emergency medicine. We just kind of risk stratify and get the risk so low that doing any more testing is more harmful than the chances of them having the disease. And we very clearly do that by ruling in intrauterine pregnancy.
I guess the first question is, can we even do this? Can we perform ultrasound in early pregnancy? And are we sensitive? Are we specific enough? Can we do this at the bedside? And there's been quite a few studies that have shown that emergency physicians are adequately sensitive at performing bedside ultrasound for diagnosis of intrauterine pregnancy. This was a meta-analysis done by Ralph Wong and a few others at University of San Francisco, California, and they looked at 576 publications, and they found that emergency physicians at the bedside have a polled sensitivity of 99.3%, which is really amazing. Negative likelihood ratio of 0.08. So this is really good. This really tells me that we can adequately perform this ultrasound to diagnose intrauterine pregnancy. These are some of the studies that they looked at here. There was quite a few of them. So one question is, how many scans are enough? And this has actually been looked at a good bit in bedside ultrasound for pregnancy. And this was a study that was performed by Timothy Jang, and he looked at taking emergency physicians and basically stratifying them by how many prior ultrasounds they had performed and looking at the sensitivities for diagnosis of intrauterine pregnancy, adnexal mass, and molar pregnancy. And he found that the sensitivities really increased impressively, going from just a few scans to more scans. So as the as the providers had more and more scans, their sensitivity basically approached 100%. And you can see here that that's pretty impressive. That not quite as much as far as adnexal mass. So unfortunately, this doesn't ring as true with adnexal mass. But for IUP, the more you do, the better you are.
So can you go back to that table? I want to see exactly how many scans does it take before you really approach that 100% sensitivity or the 99.3 that the meta-analysis showed?
Yeah, that's a good question, Matt. So in this particular table, we're talking about providers who've done greater than 40 examinations for the sensitivity of 100%. So, and you're not doing bad here at 93% or 92% either. So it's really those providers with few examinations, around 10 or so, where you're getting the sensitivity of 80%.
But it is interesting that the ACEP guidelines can recommend 25 examinations for credentialing, and this is a nice study showing that those numbers there's not a whole lot of science and evidence behind them. It may be more or less for different examinations, but I appreciate the work that Tim did on this. After 40, it looks like you're good to go.
Yeah, and I think that's shown true in multiple prior studies looking at sensitivity as a function of number of prior exams performed. There's another one of these done in right upper quadrant ultrasound, which showed fairly similar sensitivities at about the same level of examination. So there may be some evidence out there to actually suggest that 25 scans might not quite be enough to reach the highest possible sensitivity, and that makes sense. We get better at things. We get better at things the more we do.
And obviously it doesn't mean that you can't do it until you've practiced 40 times. It just means you may want to take a little longer getting confirmatory studies to feel confident and not get those anymore. Maybe not 20, maybe not 25, maybe it's 30, 35, or 40.
So the next question is, does bedside ultrasound actually save time in managing these patients with intrauterine pregnancies with vaginal bleeding and pelvic pain? And this was a study done by Mike Blivis and Paul Szerzynski, Michael Lambert, that basically showed that there was a really significant improvement in time. And they found that the length of stay was actually 21% less in those patients who had a bedside ultrasound performed by emergency physician in the ED. And the patients ended up spending 1 hour and 17 minutes less time in the emergency department, which is really pretty impressive. So you can speed up your throughput by just performing bedside ultrasounds on these patients.
And this makes sense. I mean, these are the patients that when I see vaginal bleeding on the board, I go in with the ultrasound machine. This is an extremely quick thing. Once you've had some experience with this, you see that this study is very true.
And not only that, we can look in other places in evaluating these patients, like looking for free fluid in Morrison's pouch on bedside ultrasound. And that actually predicts the need for operative intervention in a suspected ectopic pregnancy, as displayed by Chris Moore here in this article that he published, and found that basically there was a positive likelihood ratio of 112 for those patients who had a suspected ectopic pregnancy and required operative intervention. So really pretty impressive. So these patients, whenever you have somebody come in, they don't look very well, vaginal bleeding, they've got a positive pregnancy test, I often do a right upper quadrant ultrasound to look at Morrison's pouch real quick while I'm evaluating their pelvis to see if they've got an IUP. Can bedside ultrasound help with the prognosis for the patient? And this is a study that was performed by, I don't know who these first couple of guys are, but they look like, I'm not sure who this is. I don't know who any of these people are. They're probably nobodies, but they found that prospective outcomes of pregnant ED patients with documented fetal activity on ultrasound. And they basically found in this particular study that patients had a 14.8% chance of having a spontaneous abortion 30 days after their ED visit if they had a documented intrauterine pregnancy with a fetal heartbeat. So we can tell these patients to some degree that if you do have an IUP with a fetal heartbeat, you're very likely to go on to have a normal pregnancy. At least around 85% of those patients will still have a pregnancy after 30 days after their emergency department visit. All right, so let's start out with a case. So this is a 27-year-old female. She's got abdominal pain. She's had cramping for about a week, vaginal bleeding for 5 days. She was seen in an outside ED 3 days ago and had a diagnosis with threatened abortion after a bedside ultrasound in the emergency department confirmed an IUP. So her blood pressure is initially 92/64, pulse is 124, temperature is 37, SATs are 98%. She's pale, young woman, in distress. She's got significant vaginal bleeding. She's had some clots that she's passed. She feels like she's probably bleeding more than a pad an hour. This is your first image that you obtain. You initially see the patient. You're a little bit concerned because she just doesn't look that well. She's pushing hypotensive. She's a little bit tachycardic. So you take a quick look here in Morrison's pouch. And what do you see there, Matt?
Looks like some free fluid.
That's right. There's a little bit of free fluid. So you take your next shot down in the pelvis, and this is what you see. So what do you think about this image?
Looks like a pelvis. I don't really see much right there. Maybe there's some. Can't tell if that's really a uterus or clotted blood or what's going on. I really wasn't paying attention before you asked me this.
Fair enough. So not much, right? I mean, it's kind of hard to see what's going on. There's a uterus in this image, but other than that, you can't see a lot, right? I mean, do you see, like, for example, gestational sac, IUP? Do you see anything like that?
No. So, I mean, this is, I don't know if the pregnancy test is positive or not. I didn't really hear the case, but this is no IUP and positive fluid in the abdomen, so that's worrisome.
All right, so you obviously didn't see too much on that first ultrasound, so you do a quick TV ultrasound, and how does this look?
Well, it looks like an empty uterus.
Fair enough. And you scan around a little bit more, but then you see this thing. What is this right here?
It's something else, not inside the uterus.
Fair enough. It is extrauterine. It is extrauterine. So this was actually a patient who had a corneal ectopic, and these are pretty scary because sometimes you'll get images, like for example, that looks like this one, which you can almost mistake for a pregnancy actually inside the uterus because the tissue looks really similar to the uterus, and in some cases these are right up at the cornea of the uterus, which almost looks intrauterine. So it's really important that you make sure that the gestational sac is in the normal portion of the uterus. So this was a incorrectly diagnosed prior ED ultrasound where they thought the patient had an intrauterine pregnancy, and what she ended up having was a corneal ectopic, and she had rupture and ended up having to go to the OR for a corneal ectopic. So let's talk about the scanning protocol. We'll talk about our transabdominal first. And a little bit of anatomy here. So looking at the female pelvis, the thing that we're interested in here is the female uterus. And the uterus sits sort of behind the bladder here. And there's a few other structures that we'll talk about. One of them is the pouch of Douglas, which is posterior to the uterus, in between the uterus and the colon. And then the uterovesicular pouch, which is here anterior to the uterus, in between the uterus and the bladder. And these are the two places that we're going to find fluid collect in patients who have pathology on their pelvic ultrasound. So the uterus can be either anterior-verted, retroverted, anterior-flexed, or retroflexed. And basically what that means is how does the uterus connect to the cervix and what sort of orientation does it have? We're going to use the transabdominal probe when evaluating the uterus. And we like that because it's got a curvilinear footprint to it, which allows us to push a little bit harder on the abdomen. It's got deep penetration. We'll typically use the bladder as the acoustic window. So for your transabdominal imaging, you're going to want to perform that whenever the bladder is full, which can sometimes be sort of challenging because we often get a urine pregnancy from these patients beforehand. And that's, as Matt mentioned earlier, that's one reason I try to go into the room with the ultrasound, because I'll often try to perform my ultrasound even before I get the pregnancy test back, because they usually have to pee in order to get the pregnancy test in the first place. So there's two orientations that we use when we're performing a pregnancy ultrasound, and that's axial and sagittal, at least for the transabdominal view. So axial is, just like a CT cut, so you're slicing through the abdomen like this, whereas sagittal is sort of the long axis of the body here, and that allows us to see the uterus in short axis and long axis planes. So here's an example of an axial image. So again, we've got the probe marker pointed towards the patient's right side here. And what we end up getting is we see the bladder anteriorly right here. And then posterior to the bladder, we'll see the uterus in short axis. So we're sort of slicing through the uterus in like it's a loaf of bread almost. And then posterior to the uterus is here the pouch of Douglas. And then you'll often see the ovaries to either side of the uterus. The ovaries lie in between the uterus and the iliac vessels, which you can see one of the iliac vessels right here, for example. In the sagittal plane, we'll be seeing the uterus in sort of a long cut of the uterus. And here we have the probe marker pointed towards the patient's head. And what we'll see here is this is sort of the abdominal wall musculature. We see the bladder as this sort of triangular structure. And then the uterus in an anterior-verted, anterior-flexed patient is going to come up, sort of nestle up right next to the bladder here. And this will sort of get pushed back as the bladder fills up with fluid. So the bigger your bladder, usually the better your acoustic window and the better that you can visualize the uterus. Here's an example of just sort of the anatomy as compared to the ultrasound image, and you can see that here we have the bladder sitting up sort of inferior to the uterus, and then the uterus anterior to the bladder. This is sort of the cervix right here, and you can see the cervix kind of turn into the vaginal vault there, posterior to the bladder. One thing to note is if you're looking down towards the uterus and kind of pointing down into the pelvis with the ultrasound, so imagine if you're sort of getting an axial window in this cut, you can often get the uterus on top of the bladder. So sometimes it'll almost appear in an axial window that the uterus is on top of the bladder, and that's not actually true. It's just kind of coming up over the bladder and you're pointed down into the pelvis. And there's an example of that right here. So here we actually see the uterus appear to be anterior to the bladder, but that's not actually what's happening. You've sort of pointed down with your probe into the pelvis, which cuts through the uterus first before you hit the bladder. And here's that sagittal window of the uterus. And this is a normal uterus. This is a non-pregnant patient. In fact, this patient actually had an IUD, which you can kind of see right there in the center of the endometrial stripe as sort of a bright white line with a little bit of shadowing behind it. And this is just showing how you can get the uterus anterior to the bladder here. So this is the axial image here on the left. And the sagittal image here on the right. And you can see how that on the sagittal image, if I turn my probe 90 degrees and point it down through the uterus towards the bladder, that I can easily see the uterus appear here anterior to the bladder on my axial image. All right, now let's talk about the scanning protocol for transvaginal ultrasound. So for transvaginal ultrasound, we're going to be using a unique probe that we only use for a few different exams in bedside ultrasound, and that's the endocavitary probe. The endocavitary probe is a higher resolution probe. We typically use that in the early first trimester, usually around 5 to 9 weeks of pregnancy. We use the cervix as our acoustic window. So a couple things to note about this probe is that it's going to require slightly different cleaning than we perform with the other probes. Typically, most ultrasound probes, you can just use them on the patient, wipe them off with some sort of sterile cloth and some sort of antiseptic material. You usually don't have to get too fancy with probe cleaning. The endocavitary probe, because it does go into a cavity in the body, should technically be cleaned with a higher level disinfectant, and that usually means some sort of OPA or Sidex. I'm sure your hospital has regulations on this, and that's a good thing to look into to figure out how to actually clean these probes. We also use condoms for these probes, and it's also good to note that there's multiple different companies out there that make probe covers, and in most of the studies have actually shown that the probe covers are not as good as just a regular old Trojan condom. So a typical condom that you can buy in any drugstore is going to actually do better than the probe covers that are actually a little bit more expensive. So this probe does require a little bit more advanced care, which you should sort of have nailed down before you start performing transvaginal ultrasounds. The axial window, or the windows that we use in transvaginal ultrasound, are slightly different in that we'll continue to use the sagittal window as we see here on the right, and we'll get that by having the probe marker pointed up towards the ceiling. Now these probes kind of have little triggers on them typically, and you can see there's actually sort of a little notch down by the index finger here, and that is pointed to the ground while the thumb is sort of pointed to the ceiling. So I tell people when they're holding this probe to sort of hold it like your fingers on the trigger, and then for the sagittal window, your probe is going to be pointed up towards the ceiling, and that's going to give us a window through the uterus like so, which will give us a long axis view of the uterus. The coronal plane, which is the other plane that we use in transvaginal ultrasound, will be with your probe marker to the patient's right. So your thumb is now to the right, and that'll give you a sort of a wide plane, short axis view of the uterus. And let's show you those examples. So here's a sagittal window. So this is a long axis view of the uterus. I've got the probe marker pointed up towards the ceiling here, and then I get this nice long axis view of the uterus, a really good view of the endometrial stripe here. And you can see the probe marker itself is actually sitting up nestled right next to the uterus going through the cervix. The coronal window, however, will have the probe marker pointed towards the patient's right, and that's going to give us a short axis view of the cervix, and here of the uterus. And here we have a short axis view of the uterus right here. This is just some bowel here posterior to the uterus. You've got a good view of the endometrial stripe in the center.
That's quite a bit of pregnancy talk for one podcast. You know how to do the scan now. So come back next week and we'll show you what's normal and what's abnormal. Hopefully, in the meantime, you don't have the patient come in where you really need that information. Fingers crossed.
A little bit better place than we had earlier.
I can lift you up. I can show you what you want to see and take you where you want to be.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.